Continue meeting. All right. So again, thanks guys for coming. And I'd be remiss if I didn't have at least a little special thank you to Morgan Betty, who helped me put together the formatting and some of the stuff that you'll see in the PowerPoint tonight. But crush syndrome and what is the real deal? So when we talk about crush, it's covered briefly in every EMT class, MRT class, and even in paramedic school, I didn't think it was covered super in depth. So what tonight is it's a introduction into crush injury, crush syndrome, and what progresses from there. And we'll talk about basically kind of the historical value of it, where it came from, why it became such an interesting thing. And anybody that does any research or happens to be interested in it, you'll see there's not a lot of information out there, crush statistic or study wise. And probably the largest one that I can find is studied and written up in Seminole County, Florida. Fire department did a very good report on it, was the earthquake in Haiti in 2010. So we'll go through a couple case reviews. We'll start, we'll have a case review from the fire service, a line of duty death, a brief one, a brief case review from the public sector, and a natural disaster review, which will be focusing on the Haiti incident. And so as we go through, we'll talk about how things progress. And again, this is the introduction to crush injury syndrome, what we'll see. And we're going to talk a bit about time. Do we have it? Do we not have it? And one of the questions that I get asked a lot is tourniquets. And we'll talk about that. So crush, simple, compression between opposing elements, and the smiling death. And this term came about, first recorded in the first studies. They call it smiling death. As soon as you're released from the object, you're happy to be released, that patients smile and happy. And then quickly into, after prolonged crush, into immediate death. But we'll talk about that and what our goals are. So what is crush injury? Crush injury, what is crush syndrome? And then of course we hear its counterpart, compartment syndrome. Is there a difference? Is it dangerous? Are there myths, crush injuries? And then specifically, we'll talk in our case study about asphyxia, positional asphyxiation, and firefighters. The facts versus myths, what's the real deal? And there's a lot of information out there that differs, especially instructor to instructor, where you're taking your class, who you're taking your class with, and unfortunately, sometimes what the personal beliefs may be. But how dangerous is it? The common outcomes, what happens, time, studies, and we'll talk about a little bit about post-crush care as well, to get a general understanding of it. So we can see crush anywhere. We probably don't see it as much as we do our run-of-the-mill calls. But if you think about it, really, we can see it, car accidents, building collapse, structural firefighters. If we have the unfortunate incident of a trapped member or an RIT activation, even out here in the woods, Beacon Falls, tractor incidents, tree jobs, stuff like that, where we can end up with someone being crushed, whether it's a short period of time or a long period of time. So again, MVAs, collapses, machinery accidents, workplace accidents. I was able to get a report from the Department of Labor nationally about some of the statistics we see in the workplace every year. I actually thought it was kind of surprising. Trench incidents, tree incidents, natural disasters. And when we look at natural disasters, that's our largest area or times that we're going to deal with crush. And over 20% of all natural disasters include crush injuries. And in that, we're going to see, we'll break down, especially in Haiti, the amount of crush injury patients and the amount of removals they were doing per day, and amputations as well. We have our fires, terror events, building collapses, cars in the houses. Some run-of-the-mill stuff we do, and some obviously some not run-of-the-mill stuff. So the first case will be the firefighter line of duty death. The second will be the natural disaster. And the third will be the workplace injury case. We talk about all these involving either positional asphyxiation, crush syndrome, or trauma, head trauma. So the first one, we'll start with the firefighter line of duty death, is out of the United States Fire Administration, FEMA NIOSH, the report. Brian James Munns, he was a 24-year-old firefighter from Fairbury Fire Department in Illinois. He was mutually aid into a fire on an engine company, July 22nd, 2018. It was a single family residential house fire. The fire was in the basement when they arrived. His engine company was on scene shortly, approximately 5 minutes after the first engine company. They were assigned to a hose line. They made the front door, or the first floor. They come in, it's a 2-story wood frame, 1,824 square feet, and they had a enclosed porch as well. So fairly bread and butter, run-of-the-mill house, run-of-the-mill fire. As they're inside in the fire, they're a team of 4. They have 1 officer, 3 firefighters. They come in on the engine together, and they collapse into the first floor, from the first floor into the basement. Just a picture of firefighter Munez there. So he comes from a station with 27 members. They came with 5 on the apparatus that night. They do a population of 4,800 and 1.3 square miles. So in a fair assessment, they probably are a fairly busy department with that small population, that small mileage. Whereas the department they were coming to, incident command was set up off a member on the engine company. They were a small department, 40 members, but covering 85 square miles. And then the EMS providers carry for the down firefighter was at 2 paramedics on a single unit. However, it took them a fair amount of time. They're covering 425 square miles for that 1 unit. He was transported in cardiac arrest. So what they look into, he falls from the first floor into the basement. The incident commander has him back out. They use a ladder through the hole that they fell in after applying a fair amount of water to go down. The firefighter had passed down there by the time they got to him. So firefighter Munez had expired prior to being removed from the structure, and they listed his cause of death as fall, but the nature of death was positional asphyxiation secondary to being crushed. So when firefighter Munez fell through the floor from the first floor into the basement, he had 50% of his body second-degree burns, and his cause of death was the positional asphyxiation. When he came down, it ended up with a couch on top of him. When the couch came on top of him and crushed him between the couch and the water weight onto his airway, he was unable to breathe. So we talk about positional asphyxiation and crush injury together. That's certainly something that we can see at any fire that we go to if we have an incident where we may have some type of collapse, partial collapse, or maybe even Mayday or RIT type activation. So something to think about. There are other studies out there. In April, when we're at South Windsor, I have another larger study on positional asphyxiation in the fire service to include as well. The NFPA says that 4 firefighters are killed in structural collapses, separate incidences. Sure, these are from their last report of firefighter fatality in 2020. 1 was asphyxiated when trapped between floor joists. 2 firefighters are killed in roof collapses when the collapse pushed out an exterior wall. That one had struck the firefighter outside, and the other a porch roof collapse, trapping the firefighter under the debris. So it's interesting. We think it's not just maybe interior, exterior, but we have these partial collapses, these building collapses that we can see at any residential or commercial fire. When we break it apart, what I thought was interesting was something you don't really hear about is 8% of our firefighter line of duty deaths are from asphyxia and positional asphyxiation. And then 26% is from internal trauma and crushing. So we have a fair amount of our death, close to our percentage as compared to sudden death, with trauma, crushing, and asphyxiation, especially if you combine the 2 together. So what's that say for us? It says that this is happening, maybe not nearly as much as we're seeing it in the limelight or hearing about it, but these positional issues and these crushes are happening. And the trauma in this is considered or correlated to head trauma, head strikes, falling debris, and related issues. So the question to us is, what can we do to lower those statistics and on the fire service side? And then, of course, what we can do in the public sector for our patients in the field. So from the Department of Labor, people caught in or compressed by objects or equipment. So this is caught in any piece of machinery, from a snowblower to a commercial piece to a machine shop, somebody who has a limb, object, body stuck or compressed. So in 2016, we had 117. We kind of stay on course there. 18 is a little high with 137. And then 2020, we had a spike at 142. This is from the Department of Labor, directly throughout the entire United States. So if you think about it, we have a fair chance of going to a incident in a private sector or commercial business where someone has a simple crush injury. I'm sure most of us probably have gone to some type of machine incident where someone has a finger or an arm or something like that. And even though that's a small portion, right? It's an extremity or not a full body crush. It certainly is a crush injury or a compression injury, and something that we have to deal with. People caught structures, material, or equipment. So this is crushed now. In 2016, we had 82. We stayed fairly par for the course through 2019, 70, 73, 83. And then in 2020, we have another spike with 93. The 93 is also a fair amount of people. If you consider that added to our last statistic, we're up around 200 people that are either being compressed or crushed by equipment or in workplace incidences. And this does include trench. So people caught in running machines or equipment, and that's where our our private sector or our workplace study is going to come from. So in 2016, 103. We dipped down in 17, picked back up in 18 to our average. And in 2020, we actually see a drop to 89 people. So fair for the course, if you want to say we're averaging about 100 people a year in all three categories, whether it's crushed, compressed, or caught in running machines or equipment. And certainly that's something we have to do or deal with. And of course, if you think about man versus machine class or et cetera, what we can do to remove those limbs, those appendages, those fingers, but theoretically that is all crush or injury. So if we were to take the odds and play them, and if you know me, you know I love to gamble, 80% of our crush injury patients die, asphyxiation or head injury, and that's 80% on scene. So 100 patients in a collapse, 80 of them are going to pass on scene asphyxiation, positional, or head injury trauma. 20% of these patients, so again, we use simple math, 120 of them are going to reach the emergency department. They're going to be extricated by the fire department into their EMS transport and brought to the ED. What happens from the ED is that we see 10%. So out of those 20 that go, 10 of them are going to recover. So we have a very low recovery rate, which leads us back to the exact thought that I'm sure everybody already knows or thought about, but high frequency, low risk, low frequency, high risk. Crush injury certainly is a high risk, low frequency type incident. To me, it says that what we need to do is take that 10% out of that 20, and what can we do to make it that they recover? What can we do for that extrication? What can we do time-based or care-based in the field as firefighters, first responders at our level? Obviously, with the severity of the collapse or severity of the trauma or the crush, we understand, I mean, 80% is what it is. And when we look at our studies too from Haiti, you'll see that the numbers are even that higher, 200,000 plus. But we have to focus on the other 10% that we can have any type of tangible effect in. At least that's my opinion. So historically, and interesting, Ciego Manami, 1923, he reported on 3 cases of soldiers who died from renal failure caused by crush, and this was during World War I. So he takes these studies microscopically and investigates the pathology of the kidneys. So auto-intoxication, which later, of course, we describe as rhabdo or rhabdomyolysis. So this is the very first study, 3 soldiers all crushed, World War I. And it doesn't take much gas. It's there, people are realizing it. And then it starts to really take off in the World War II era. Crush syndrome and compartment syndrome become largely studied. World War II, multiple bombings, larger. We're seeing more building collapse, more people crushed. So a paper coming out in clinical research and a study, the paper is titled Crush Injuries with Impairment of Renal Function. This is Bywaters and D. Bell's paper that they submit. And what it comes out to is they, of course, confirm our renal failure, our crush, and the result or our need for emergency fluid replacement in the field. For you guys who know me, I have to put in a little nerdy historical EMS references here and there. But this case was interesting, especially for our topic, and we're going to talk about time and what we can do. They studied 4 people. All 4 of these were a result of the air raid during the war, caused on the crush syndrome injury as its own and important issue. What was found in those cases is misrepresented. Sure, the cases all focused on patients who were stuck under heavy debris and masonry debris for multiple hours. And I think that's the important part here, that when we think all the way back to these very first studies about it, we're talking about multiple hours, not people who were under this debris for 10 minutes, 5 minutes, 15 minutes, 30 minutes, but for over at least 4 hours. These patients then presented in the ED, which appeared to Bywaters as completely stable condition, of course, with the exception of limb injury or amputation. So a lot of these findings, mostly in common, was victim presentation, outcome medically. But like, again, I said, for our interest really, to me, was the time. So notably in our first case from Bywaters is a young lady, 17 years old, air raid victim, and she was crushed in by masonry debris for over 9 hours prior to her removal. Post that 9 hours, they remove her. She presents to the hospital with limb swelling and extremity pain, however, alive in what appeared to them at the time to be stable condition. All the cases they studied, reviewed, involved patients who had been buried or crushed for multiple hours, and most of them over 4 hours. So when I read that, it said to me is if we can remove them post that time and they make the 10% that make the emergency room, even back in World War II era, then we must have some commonality between time now and the patients that we see now and what we can do in that time frame. Just a quick screenshot of the first, the victim, the female, and then the front page of the study. I read most of the study, and again, like I said, it starts off with a 17-year-old girl, but at 9 hours, which is a considerable amount of time for us, with a lack of pre-hospital care, a lack of pre-medical care, right? We're talking military. So we go on and we talk, we have crush injury. And as things progress, we start with the actual initial event. We move into crush syndrome. We see compartment syndrome. And then overall, we're going to end with what we've seen as renal failure, acute kidney issues, renal failure. On top of that, of course, other things, whether we have head trauma, asphyxiation, or if we're going to see field removal where we're not able to extricate, and we're going to talk about amputations as well. But all starting with the original injury and then progressing through. So what happens? And I know this isn't based for a lot of EMS providers. I know there's a lot of paramedics and EMTs in here, but I wanted to include just a quick review of some of the terms that pop up in these studies or pop up when we talk about crush. Hypovolemia, a decrease in the volume of circulating blood in the body, right? So a traumatic injury or severe dehydration. Hypovolemia, shock, hand in hand. We're bleeding out, we're losing circulating fluid. For those of us that are just firefighters, we're losing that water in the lines, right? We're not circulating back to the pump. Hyperkalemia, so that's the presence of abnormally high concentration of potassium in the blood. For those of us that know, potassium is not great, especially in high concentrations in our body. Hyper K is something that we can see in the field, specifically on a EKG, on a 12-lead EKG. Ventricular fibrillation, a rapid, uncoordinated fluttering, the contractions of the ventricles or the heart, and basically we're going to lose that synchronization of the heartbeat and the pulse. Of course, anybody who's been to a cardiac arrest, VFib is certainly something that you know about, or CPR, et cetera. Anything in blue, and I should have noted this before, that you see is where we're taking some of these definitions, these terms from. And again, everything's referenced at the end. So what happens as we continue on about our review is we're going to talk about rhabdomyolysis, because ultimately a lot of this is going to come down to that. So if you look at the image to start, the blood vessel, we become with that damaged muscle, and then we start with our rhabdo. So this occurs when damaged muscle tissue releases its proteins and its electrolytes into the blood. These substances damage the heart, the kidneys, permanent disability, or death. If you think about it, we're damaging this area, and when we're damaging it, we're injuring it. So we're making these bad products, or we're releasing these bad products. I don't want to call them like free radicals, but if you think about it as waste or damaged product, now we're going to start to flood our body or flood our system with these damaged and wasted products. So a quick review of VFib, simply just uncoordinated. This is a shockable rhythm. Why we talk about VFib is because VFib is the most common dysrhythmia to occur in a patient, leading to sudden cardiac arrest post-removal from a crush injury. Second, obviously VFib leading to cardiac asystole. This is death. There are very few documented cases with immediate transfer from this. And then hyperkalemia. This is where we're building up, and we talked about this potassium, or this hyperkalemia comes in, and we start with our normal P waves, our normal rhythm. We start to see a flattening in our P wave, and our P to R for the non-EMS folks there is highlighted, and we start to see this flatten out in our heartbeat. And then we come over and we have a very peaked top. So we know that we're dumping this potassium into the system, and as we're dumping this waste in there, for lack of better terms, in this product, we know we're going to start to have problems. We know the body doesn't want that. Shock, again, hyperperfusion, but basically our signs and symptoms we're looking for: low blood pressure, high pulse, high respiratory rate. Cushing's. We talk about head trauma, and we talk about head strike as part of crush, absolutely. And in Cushing's, we're going to see the opposite. We're going to have a high blood pressure, low pulse, low respiratory rate. Renal failure, kidney failure Our kidneys lose their ability to filter out our waste products. We build up in the blood. When we build up this waste product in the blood, our potassium and our exchange isn't working. We're not filtering correctly. We change our chemical makeup and our balance, and we start to flood the system with these, per se, bad things, these things that we don't want in there, going on now to harm the rest of our healthy tissue in our body. One sec, it's trying to change the slide here. Crush injury carrying on. So when we talked about progression, so we're starting with our crush injury, we have to start somewhere, and that's the actual physical trauma. So crush injury is a physical trauma from the prolonged compression, torso, limbs, and or parts of the body. So crush injuries represent a range of conditions, direct or indirect trauma. And of course, we've seen that indirect, direct, we can see a car accident, we can see a building collapse, incidences like such, people, cars on top of them, people working in a garage, any melee of incidences that you can go to that you think involve trauma. So crush injuries usually only involve superficial tissue. However, when severe, they involve muscle, tendon, and bone. So we're going to start with the physical injury. That's the crush. The item comes down, it's onto us, it injures us. We may see some broken bones, some broken skin, etc. But where does it progress from there? Well, it has to go somewhere, and that's where we get into crush syndrome. So our common definition of crush syndrome is a physical response to severe crushing, injury of muscle. Of course, obviously, this is our muscle tissue, especially shock or partial complete renal failure. This may be over time. Our medical definition from the US Library of Medicine says crush syndrome is a series of metabolic changes produced due to an injury of the skeletal muscles of such a severity as to cause a disruption in the cellular integrity, release of its contents into circulation. So if we were to break it apart, we have our initial injury, and then we go into crush syndrome. Crush syndrome is bad. That's where we're starting to have more of our negative outcomes. This is where we're starting to get concerned about patient extrication, prolonged time, ALS on scene, where we're transporting to. So crush symptom, or crush signs and symptoms: hypotension, shock, bleeding, open fractures, open wounds. And not only with open fractures, open wounds, do we worry about crush stuff too, but I mean, for those of you that are thinking, it is absolutely correct too, that we're gonna have to worry about infection and wound care as well, skin injury and swelling, pain, paralysis. And then when we have a loss of a palpable pulse in that area. So we're checking our PMS and suddenly maybe we don't have sensation, we have abnormal sensation, we might not have movement, or we're losing that palpable pulse to that area. That obviously is bad news for the patient. In our progression from crush injury to crush syndrome, we come into compartment syndrome. So this is, I kind of consider it our third stage. And compartment syndrome occurs when the pressure within a component increases, or a compartment, increases. So we're restricting that blood flow, right, to the area, potentially damaging these muscles. Well, potentially, sure, but we're definitely going to start to damage these muscles over time. We're not allowing any of that healthy, good blood, that exchange to occur, all that, what we need, the nutrients, oxygen, all that to come to this area. It usually occurs in the legs, feet, arms, hands. Of course, wherever we have an enclosed compartment of muscle and tissue, we can see compartment syndrome. So obviously, it's very simple to tell our progression. We receive the injury, how long we were there, we have crush syndrome, we start to build up this waste, or even if we're losing blood, we're having these injuries, and the compartment is well within that area. If you want to think of compartment syndrome in a simplistic term, think of it as taking an area of muscle, or again, compartment of that muscle tissue, and then putting a zip tie or rubber band on it. And we're building that pressure up. And that's where we're going to start to see the problems. We have two variations of compartment syndrome: acute compartment syndrome, which is sudden onset, notably after sudden fracture injury, right? And we're talking about secondary to our crush injury, or chronic compartment syndrome. Interesting about chronic compartment syndrome: slow, gradual onset, often after repetitive exercise or muscle movements. And I hear a lot about this. And if you read up, sometimes people refer to long sets in gym athletic workout, or CrossFit related to that I've heard. So you're doing these slow, repetitive, or often these fast and repetitive exercise movements, muscle movements, and we build up in that area. Suddenly our arms are sore to move, or we have that burning sensation. Sure, we compare it to lactic acid, but also in a form of rhabdo. So we have sudden or intense pain, tightness, tenderness to the area, tingling, burning, numbness. Why is this important to us? Well, it's important to us because we're probably going to be the first providers at the patient as firefighters, as rescue people, as EMTs, MRTs, and even sometimes paramedics. We may be the first, or firefighter paramedics especially, the first people at these patients. So we can kind of start to base our idea off of where in the system or where in this progression is our patient at. Well, acutely, if sudden intense pain, sure, that can come with crush injuries. Sure, it can come with crush syndrome. But now compartment syndrome. Do we have the tingling, the tenderness, burning, numbness, sensation, lack of palpable pulse? Okay, and then of course chronic, when we talk about people, again, repetitive movements, repetitive muscle movement, working out. And that's where we're going to see things that most of you guys are probably used to. You know, you're working out in the gym, you're doing a lot, or you're doing repetitive action over and over again, cramping in the area, pain, soreness, swelling, pale skin. Maybe it feels abnormal when you touch, or you feel cold to the touch. So what's the difference? Well, obviously they're life-threatening. They're all extremity-threatening emergencies. Both are traumatic in nature. But crush syndrome is the prolonged pressure of the muscle group, and compartment syndrome is the prolonged constriction within the area. So this is where the pressure not can be confused with crush syndrome, where it's prolonged and out over the area. This is where the pressure becomes redirected to the deep tissues, our inward area, our inward structures. This is where we cause damage. So all that pressure has to go somewhere now. So where's it going to push everything? It's going to push it into that indirect area. We have to move that somewhere as it compresses down. So just a quick chart that runs through it, but basically says the same thing and what our symptoms are: acute compartment syndrome, increasing pain, feeling of tightness, numbness, diastolic pressure less than 30, sure. And then of course over to crush syndrome. So what happens? Exactly what we would assume happens, right? In either of these issues, the outcome's similar. So if we look at the pathophys quickly, we see rhabdo, we see destruction of muscle tissue, skeletal muscle tissue. So this causes the release of the cell content into the circulating bloodstream. When we release this cell content, or this waste, for lack of a better term, into our systemic circulation, we start to see these issues. Of course, if we have open trauma, we'll start to see hypovolemia. We have closed, or we're building up with this potassium, this waste, we're going to see hyperkalemia. So two things that we talked about earlier, and we saw on that example of the 12 lead there. But also, we're going to end. Renal failure is our outcome, acute renal failure, right? Sudden onset. So as this occurs, sudden dysrhythmias can occur. As we see this change in this chemical makeup, we can see sudden dysrhythmias, and the most common in crush injury or crush syndrome of these patients is going to be VFib, ventricular fibrillation. So sudden cardiac arrest. All of us who have worked in the field know that sudden cardiac arrest is VFib. We can shock it, we can try to treat it. Most likely though, where we headed, asystole, we're headed to cardiac death. So this is related to the lack of calcium and the sudden increase of potassium. Our normal exchange isn't occurring. That good, healthy transfer filtration is not occurring. Boom, all this potassium rushes in, body freaks out, something's bad happening, heart goes haywire, we go into this fibrillation, this movement, heart can't handle it, into asystole. So essentially, we can just really state this as a sudden rush of waste into our systemic system, into our circulatory system, causing just an extreme amount of sudden damage. The waste comes in, it's released into the blood, and what we're looking at is serum creatine kinase are basically abundantly present in the blood. This can be a result of the hypoxia, and when we talk about that relates hypoxia, lack of oxygen, directly to our positional asphyxiation, whether it's the crush injury person and or our firefighter example, our line of duty death example from before. So these releases from the cells into the bloodstream, and this is post-injury. So the enzyme has negative effects on the body, obviously, of course, because we're releasing the levels. Normal levels in the average adult, 25 to 175. But in crush, we're going to see levels greater than 1,000. And relating back to that historical study in World War II, they started using that measurement as the basis for saying, okay, we are in crush syndrome and moving to compartment syndrome. What was interesting though, and I keep bringing all this back to time, is because we always hear about time, this takes 2 to 12 hours post-crush. So 2 to 12 hours on average to get up to the level of 1,000 or greater. It peaks at 3 days and then declines from day 3 to 5. Of course, we'll see elevated lactic acids and correlate to ischemia. So basically what's happening, the kidneys come to a halting stop. But keep in mind, 2 to 12 hours post-injury. So fact or myth, I think that we hear a lot of stuff, especially newer EMTs or MRTs or firefighters, and we hear about things from other firefighters or other medics or other providers. And when we talk or we teach about crush, there's not much about it. And one of the things we always hear is, okay, time, what we can do, what we can't do, we shouldn't go rushing in. Well, if we look at time, does time really matter? Absolutely, of course, time matters, but is time based off the research correlating to these actions we're taking? Are we hurting our patients or victims by removing them too soon? What kind of extrication is it? Do we have simple, complex, technical extrication? And the time that it takes to do this, are we damaging them beyond perhaps what they already have from that injury? Well, looking at the time, I think we can all formulate an opinion on that. So let's talk about time. When we have a crush victim, I think that as rescuers, again, firefighters, providers, whatever, we should keep a couple things in mind. And one of the good takeaways I took from the studies was 4 R's. So rescue, resuscitation, recognition, and rehabilitation. If we're going to talk about time and how soon we should be doing something, well, to me, what stands out is that the first is rescue. Rescue is most important, right? Resuscitation. That doesn't necessarily mean cardiac resuscitation. We're talking about having providers on scene, ALS on scene, and the big thing is going to be fluid resuscitation. Recognition, understanding what part of the process we're in. Are we early on? Are we at crush injury? Are we a little bit further in? How long has this patient been there? How long did it take us to access them? Okay, maybe we're 30, 40 minutes in. Maybe we're just at crush syndrome. Maybe this patient's been out in the woods logging for 5, 6 hours. Maybe we're at compartment now. But if we can recognize kind of what's going on, we can start to make our basis on how quickly we're going to move them or extricate them and what resources we're going to need. So when we look at time, crush injury is immediate. Well, that's a no-brainer, really, when we think about it. Of course, it's immediate. It's going to be the direct result of the event that we're being part of, whether it's the crash or whatever. But crush syndrome takes approximately 4 to 6 hours for most cases. In very, very severe cases, I saw noted as soon as 60 minutes. That's still an hour. If we're talking an average response time of 5 to 8 minutes on scene, maybe 5 to 6 minutes to get to the patient, what are we, 12 minutes in? Are we well outside of that crush syndrome window? Sure. We're 4 to 6 hours on average. So that gives us a fair amount of time to think about, okay, we can remove this patient, and they're probably going to be, if we think back to that original study, in that stable condition. So skeletal tissues can withstand ischemia for approximately 2 hours. So is it still reversible? Yeah, at 2 to 4 hours, it starts to become irreversible. And this is our skeletal, and I should have added to our skeletal and muscle tissue. So if we can withstand ischemia for 2 hours, that certainly, again, correlates to our 4 to 6 hours, giving us a fair amount of time to arrive at the patient, remove the patient from the situation they're in. Irreversible damage to these cells and these tissues is approximately 6 hours into our event. 6 hours into our event is an extremely long time for our run-of-the-mill crush injury patients. And I would assume everybody would agree with that. We're not going to be on scene cutting someone from a car for 6 hours. We shouldn't even be there cutting them for 60 minutes. Same thing, simple injury. Guy gets an arm stuck in a piece of machinery in a factory. Where are we at, 30 minutes, an hour? It's okay. So crush syndrome requires more than hands and feet to occur. Absolutely. If we're damaging just a phalange, for example, but we need large body areas for crush syndrome to occur. So prolonged over a period of time. Again, that large area is crushed for 4 to 6 hours. 4 to 6 hours is much more beyond normally what I would say any of us are going to be on scene. Compartment syndrome, so the third of our levels, right? Crush injury, crush syndrome, now compartment syndrome, where we see that compression inside those muscle compartments, anywhere from 3 to as late as 48 hours post-injury. 48 hours. So what's this mean for us? In my opinion, it means that we have time. We have time to get on scene, and we have time to remove that patient without wildly negative outcomes. We see it all the time. We remove that person whose legs are pinned under the dashboard. Crushed. We remove that person whose arm or hands might be stuck in a piece of machinery. Crushed. 2 to 4 hours for our original onset, all the way up to 48 hours for compartment syndrome gives us plenty of time to remove our victims safely, transport them to the hospital. Now, does that mean that we can just rip them out, throw them on a stretcher and transport? It may in some cases. That might be what we have. We might only have a BLS transport. We might not have anything available. But what we can do as rescuers is we can initiate that immediate extrication. We take the totality of the situation in, how long has the patient been there, recognition of where we're at in the process, and we rescue. How long was the victim trapped? What do we need for stabilization, equipment, manpower? Sure, all considerations for us. But if we're coming in 1-2 trucks off the rip, we're okay. We're not outside that 2 to 4 hour area. We're not seeing ischemic tissue where it's not reversible past that 6 hours. Best thing we can do these extrications quickly. We can have ALS on scene. What if we don't have ALS? That's a question I got asked going through this kind of practicing before. Well, if we don't have ALS, we're going to do what we've always done. We're going to put them in a BLS ambulance and we're going to transport. The ultimate goal is get them to the hospital, get them to the hospital alive. But if we have ALS care on scene, that's going to be kind of our golden standard. And we want to start that resuscitation, IV access, and getting fluids into that patient. Of course, there's the debate, bicarb, no bicarb medications. And that's relative to where you work, what your medical control is. But a question that I was asked is, in these crush injuries, is specifically public and private, fire and public sector, what happens if we just can't extricate them? And of course, that leads to the question of amputation. And does amputation correlate directly to crush injury? It does. And we'll see that the biggest study that I can really read up on that is in that Haiti case study. So if extrication is not possible, we're going to have to start thinking about amputation. Now, amputation, we're on scene a long time. We're going to have to start thinking about maybe perhaps what resources we're bringing in, Sharp's team, Yale, Hartford, et cetera, et cetera. So we should have our transport ready if we can. Ground versus air medical. I think of it when I do EMT class really, or whatever, teach class, it's the same as any other major trauma. If we can't extricate them in 45 minutes, air medical certainly is something to consider. Ground transport, let, of course, the receiving facility know early. And again, if some of this information is maybe under some of the people here, I'm sorry. It's the introduction or a basic understanding of everything. So of course, for those of us that know, or command or whoever, let's notify the receiving facility early. EMS, aggressive fluid replacement, cardiac monitoring. Be prepared for that sudden change. Document and critique the incident. One of the best things I read throughout this, and that will bring in April, is some critiques from incidents. But amputation, crush, entanglement, and asphyxiation. So we'll start off with a case study here from Green Bay, Wisconsin in 2005. What I thought was very interesting in the Green Bay Fire Department here is that a career firefighter paramedic performs a field amputation, something you certainly don't hear about, I think, especially around here or our field very often, if ever. A public works employee, he was at their shop, he was cleaning out his sander post-snowstorm. He's cleaning the sander, the truck is running, the sander is powered, his arm becomes entangled. He is sucked into the auger. And we're talking, large DOT-style truck. He becomes sucked in. He's entangled. It stalls the motor. However, this left the victim entangled and crushed between the inside of the sander and the body of the sander. So if you think about that, and we've seen these before, it's a pretty small space to be in, pretty confined. This caused positional asphyxiation when the top half of his torso and his body was in there. So they came up with this game plan, and their solution was, what we have to do is we have to amputate the arm to be able to remove the rest of the body and the torso to stop this asphyxiation and this crush. So we talked about positional asphyxiation before, and crush, we certainly have it in this case. He's crushed between these two objects. He's entangled in these two objects. And their plan was to do a field amputation. But what comes from this, and what I think is interesting, is we get asked a lot, and I should be fair to finish that off. This man from Public Works, he did not make it. He passed after arrival at the hospital. He had been entangled for a long period of time. They had to walk through the process of the paramedic and the field amputation. And what ultimately is that positional asphyxiation from the crush. But fact or myth, tourniquets. And this is something that I got talking to Dan with at the expo. Everybody sells a tourniquet. People give tourniquet out, stop the bleed class, tourniquet this, tourniquet that. We have a lot of tourniquets. And one of the questions was, well, why can't we tourniquet somebody and then remove them? Why can't we put that tourniquet on and stop that bad blood flow? Well, I want to think about it like this. If that body, torso, appendage is crushed and it's cutting off that circulation and building up all that waste, that's essentially doing the same thing as a tourniquet, right? It's when we release the patient, release them after multiple hours, or in most cases, that rush of badness comes through and we see our renal failure, our sudden changes, our death. So Arana Bindri, if I'm pronouncing that correctly, but Critical Care Medicine Journal, he writes about tourniquets, and applying tourniquets for more than 2 hours may cause rhabdomyolysis. Okay, makes sense. Neurovascular damage, sure. So the current consensus to avoid using tourniquets. Now, I noted that there's, of course, 2 exceptions. There are some theoretical benefits. And of course, I'm sure we can all put that together, right? There's a theoretical benefit because the patient in whom intravenous access can't be obtained. So if we can't get IV access and we can't remove our patient immediately, and we're going to be on scene a long period of time, then maybe this tourniquet can delay onset of reperfusion syndrome and help with our onset of rhabdo. Obviously, it's going to help with our hemorrhaging if we have that. So we take the tourniquet, and the myth that you cannot use a tourniquet for these situations is incorrect. Yes, I have to put in the caveat that it can vary from practice of this method by where you are, what state, your medical control. But in relation to this critical care article we see pertaining to crush injury, the absence of an IV, so if we can't get one, we can't place it, maybe we can't get an IO, I don't know how, maybe the entanglement's so severe or we can't get to the patient fully with our equipment, who knows. But when the patient has been crushed for greater than 4 hours and the extrication is impossible, or impassable, to apply a tourniquet for a short term until the IV can be obtained and IV fluid resuscitation begins. So what's that mean for us? It means, yes, we can still use a tourniquet as always when there's life-threatening bleeding. We see in our picture here, we actually have 2 commercial tourniquets applied. So if we cannot get an IV, so we cannot provide that fluid replacement right away to dilute and circulate and push out that waste and put in that good fluid, then let's do that. When we are ready to remove them, we can't get that IV. In certain cases, yes, a tourniquet can be applied, and the tourniquet will do the same thing that original crush was doing. It's compartmenting off or keeping back that bad stuff. If you look into our protocol, there's not much on it, so it's very interesting theory. So you always hear people say, well, we can tourniquet stuff. So yes, the short-term answer is, although not widely used, in the event where we can't get access, or the event where we need to maintain that, we can use a tourniquet. And the 2 articles that I read suggested using 2 tourniquets. When we take that into consideration, we'll look at Haiti. Haiti, large earthquake, 2010. January 12th, I'm sure a bunch of us remember it, but this was a case study from Seminole County Fire Department in Florida that I read about in correlation to their development of crush SOPs and crush injury, how they're going to treat it, and what they're going to do when it's time for amputation, when it's time for removal. Again, in April, when you come to that, we'll actually have that SOP up. Emailed them in an attempt to get it. Case study, so second leading cause of death was crush injury and crush syndrome. So pretty interesting that the number 2 issue here in Haiti was that approximately 1,100 crush injury patients, or 11%. The average trap time for these patients in Haiti was 31 hours. So 31 hours. Let's think back to our original time where we were worried about 60 minutes. These people have been alive in this for 31 hours. There were an estimated 200,000 dead and an estimated 250,000 injured. When set up for field care, they were averaging 30 to 100 amputations a day, secondary to crush syndrome and removal of patients from the debris. So 30 to 100 a day. When we're talking, maybe if we look back to our department statistics, maybe 100 in a year here in America, during this particular event, they're doing up to 100 a day. And the study followed 8 of their most severe cases. All 8 of these patients ended with renal failure, of course, and 2 recovered. So what's this say to us? So it says, again, that we're in that odds. We're in that 80 to 20 to 10% odds. But it says that amputation can be successful. They spent weeks digging people out post that. The longest surviving one that I read was 48 hours. So I think that's interesting to think about, is that if we have to make that call for amputation at these crush injury patients, that we certainly can. And that amputation can be a successful means of removal of the process. And amputation, of course, in Connecticut, we have to call out what is going to be our Sharps team, et cetera, to come out and do that process. That case study in Haiti goes on for quite some time, and reading about success rates and people who were crushed, and about 15% regained back to complete, or what they consider complete normalcy, which I thought was pretty good. So post-scene care, what happens to our victims, our transport, and that 10% that we should be focusing on. So we need to focus on that 10% that we can improve. Dialysis, we talk renal failure, and all of us know, or worked on any type of ambulance, dialysis. It's going to be the mainstay in care, right? Acting in place of the damaged kidneys and filtration. The 3-day-a-week episode. Hyperbaric O2, so reoxygenation or hyperoxygenation, helps to reduce the swelling, infection control in that area, the blood vessel and collagen formation, reduces those free radicals and reperfusion injury. So it's helping everything. It's helping push in that oxygen, exchange that good stuff for that bad stuff. It's helping with our wound and our injury, helping to replace. And then ultimately, when we see compartment syndrome, we're going to talk about fasciotomy. Now, of course, there's other treatments for this. We're talking about hospital stay, antibiotics, IV fluids, some know up to 1,000 an hour over the first 4 hours. Of course, burns if we're burnt, or other miscellaneous injuries, fractures. But ultimately, coming down is we're going to talk about fasciotomy here, which I do think is interesting. And this is used to decompress the compartment syndrome. So essentially, surgeon opens up that area to release the pressure out of that compartment. So we talked before about having a rubber band or a zip tie as an example over a muscle package. Now we're ripping that open and we're allowing all that pressure to escape. This improves our blood flow to the area. It helps our reperfusion. It helps our ischemic tissues. It overall improves the patient's outcome post-compartment syndrome. So fasciotomy. It goes on, of course, if you read more about it, covering it up, skin care, skin grafts, etc. So our key takeaways, so what we're dealing with, crush injury syndrome, compartment syndrome, and kind of just a brief overview of all of these. Again, it's introductory onto what we're dealing with and some of the basic informations about it. Low frequency, high risk. Time is not our enemy. And I think we can definitely tell that from the times that we're seeing. I mean, at 60 minutes to 4 hours, theoretically, if you want to combine them, that gives us a long time to get there and to immediately start our extrication and remove the patient. So time's not necessarily our enemy. We need to know our time frames. How long has our patient been there? And what our outcome or what our recognition is going to be. Tourniquets do certainly have a place in the field of care for crush injuries, especially when we talk about these long-term issues where maybe we're not going to be able to get access for fluids. Maybe we're not going to be able to get, that IV, or we're going to go about the amputation route. And of course, as always, with our major hemorrhage or our lack thereof, we use our tourniquet as normal. So what happens to our bodies when they're crushed? We talked briefly about the pathophysiology behind that. And essentially it all boils down to, again, that rush of waste. And that rush to waste is what's going to hurt us. Yes, can we have sudden cardiac arrest? Sure. Can we have long-term negative effects? Sure. That's part of the game. That's where we're focused on, that 20 and 10%. Okay, what our post-scene care is, and most importantly, a basic understanding of crush, making us providers more confident in these situations. I hope that some of this information made us more confident in thinking about our crush patients, thinking about our time, thinking about how simple some of it can be. The motor vehicle accident, snowblower, arm under a piece of equipment, stuck between the boom of a machine maybe. It's not always going to be the major collapse or the buildings on top of me or a plane hits Cal Brennan. It's not always going to be those things. We can hope for maybe that last one. But with that being said, I want to thank everybody for coming and letting me run through this tonight. I hope that we see some of everybody in South Windsor in April, and we'll have a continuation on of this crush injury, as well as a continuation on of these case studies. And basically take away from it that we don't have to be as scared as maybe some of us might be with Crush, that we have time, that we can make these extrications, we can do these rapid extrications, and knowing our resources and knowing what our outcome may be. The more we can understand about the situation, the better it is. So we have the knowledge to replace that fear. So thank you guys for coming. If you have any questions for me, you can hit it in the messages. Most of you know me. You can text me, call me, get in touch with Dan. Look forward to seeing everybody. Thank you guys for coming. Thank you for listening to me ramble on about Crush. And again, it's a unique situation that we're learning more and more about all the time. My references are all here: medical references, reviewed journals, Institute of Health, NIOSH, FEMA. So thank you guys for attending. That's my email address. If you guys want, or you need my phone number or anything like that, absolutely. And one thing to keep in mind is that I am going to put this in for CAPC credit, for CME credit for a basic level provider, and see if I can get it for advanced from the state. So if you're interested in that, or you think that you need that credit, whatever, you can just shoot your email over to me. I'll write it down, and if it gets approved, which it should, we'll send out a certificate for you for the CME hours. So thank you guys again. Thanks for coming. I really appreciate it. Thank you, Dan, for having me. And I hope that was a good basic introduction, understanding the Crush and where we're going to take it from there. See everyone in South Windsor.
Thank you guys for joining. Just 2 seconds.